Good afternoon, everybody. So my presentation will be very basic. So you can ask question 10 minutes. I'll try to finish. I do not have any financial disclosure to make in this presentation. Now, case of number one is very interesting. 58-year Indian male from Northeast India. There's a dimness of vision in the right eye for 18 months, and there was diagnosis of neovascular glaucoma and retinal detachment in that eye from elsewhere. No other significant history, and there was no perception of light in the right eye. Left eye vision was okay. There's iris shows some neovascularization at certain quadrant. IOP was 43 mm of mercury. There's a dense cataract in the right eye. Fundus not visualized. This is B-scan ultrasound showing the anterior border of a mass in the vitreous with a high spike, then incremental decrease in the spikes. Okay, this negative kappa angle, which in the lower portion there was some excavation can be seen, and sonologist has opined that it's a choroidal melanoma. CT scan was done because patient was from economically poor patient. So we have done and we have seen the mass there, and other investigations were normal. So since there was a painful blind eye and secondary glaucoma, I was enucleated and different measurement was done for this. Transillumination defect shows a internal tumor, and cut section showed a brownish pigmented mass with exudaretinal detachment. This is the exudaretinal detachment, and this is a collar stud mass that we have seen. Now these are the stain which I like to address. When you get a one-half of the eyeball, you can explode this. For example, I have stained with fluorescent stain, whether I can catch those cells there. And these are the crush smear cytology that you have seen. Again, you see the crush smear cytology showing a pigmented cells in the gross specimen. Now, here you can see in the fluorescent note, the epithelioid cells can be visible, which were later confirmed in histopathology. In permanent section after 3 days, the cornea was normal, angle was a bit closed here, and there was a choroidal melanoma with a pigmented cells. When we did in high power, it showed epithelioid as well as B cells, spindle cells. These are the, you can well appreciate some epithelioid cells here, and here there was a peripheral cystic degeneration was noted. Now pigment cells migration was seen in the sclera. This is very, very important why I am showing this. Now we see this is the exit of the vortex vein, and here the pigment cells are seen. So these are very important to see the vortex vein exist, and the cut end of the optic nerve was normal. This is basically important for retinoblastoma, but we even have to see in the eyeballs. And now here you see some spongiosperm appearance in the sclera around the tumor. We have done a Elsian blue stain which showed some deposit here, and trichome stain also showed some deposit there, and HMB45 showed the in ISC showed the pigmented cells, and KI index was 30 to 50%. So this was a biphasic epithelioid and spindle cell with HMB45 KI67 involvement. So choroidal melanoma associated with spongiform scleropathy that we have published this. Case 2 is again a very interesting. It is 70 years old Indian male with dimness of vision of the left eye now, progressive in nature, and there's a lump in the back of the patient. Okay, that's, we have seen this patient during the COVID time. So when the vision was poor in this case, and also the pressure was shoot up, and we thought that pressure was 28 mercury. There's a dense lenticular haze and perception of light in the left eye, and it was also enucleated. The measurement, etc., were done. And you see, oh, this slide came before. In B scan again, you can see with the there were collar stud appearance with excavation can be seen, and in CT scan also the lesion could be elicited. Now we see in transillumination, here we could not get too much information, but in cut section there's a pigmented tumor with exudaretinal detachment, portion of the lens was seen. Again you see this raw specimen, because other half we do not use for the purpose, and you take a small snip of the tumor and you can even see the epithelioid and cells like picture in this raw specimen. Normal cornea, normal iris, normal ciliary body. There was exudaretinal detachment in the vitreous cavity, and vitreous cavity showed pigmented tumor with epithelioid and spindle cells. Again, it is customary to do a optic nerve curtain examination, which was normal. So again, this is again a biphasic, both epithelioid and clear cell tumor with ciliary, part of the ciliary body thing. An important thing for the pathology is to group them into HGCC 8 staging, whether it was 2B and T2B was there, and histological grading was grade 2. So we can make a histological grading and HGCC typed in front of your thing when the specimen come for retinoblastoma and other thing, and you group and give the clinician the HGCC classification. That's very important. So both the tumor had a breakthrough Brooks membrane, that is a collar stud appearance in this case, and in first case we saw melanoma associated spongiform scleropathy, which is usually seen in 38% of cases, and there is a collagen degradation near the tumor. What is important in this publication and this case, we have not done a biochemical analysis in this case, and if you get those cases, if you can do in the future biochemical analysis, this gives a very important result for your pathological finding. To sum up the pathology of choroidal melanoma, so this is what Professor Shield has given for small melanoma, TFSOM UHD. This is very, very important. Usually thickness is more than 2 mm in melanoma. You find subretinal fluid. You get a symptom of flesh as orange pigment. Remember, in melanoma you get an orange pigment, but in benign nevus you get drusen. Okay, ultrasound hollowness in benign, and major factors are more than 2 mm, orange pigment, it is lipofuscin pigment, and fluid. So in clinical case you get a B-scan ultrasound, and in histopathology same choroidal excavation and other thing can be representative. Now you see you get a specimen in like this. Always remember that educate formalin is there in the specimen, and what is important here is that marking of the vortex vein. This is very, very important, okay, and you have to see this thing there. And you see this is again a large melanoma, and you see base of the tumor and the anterior posterior diameter is very important, because what is there, you need to have small melanoma, medium-sized melanoma, large melanoma, and extra large melanoma according to COMS study. Now you see these are all being seen in the rapid fluorescein stain. These are the spindle cells and epithelioid cell. What is important is that sometimes a masquerading tumor can be in the vitreous cavity, and there is always an issue that no, you cannot catch up in the what you called in the smears cytology. Always clinician complain to the pathologist. Okay, you can make a number including a what you called a fluorescein stain. If you see, if cells can come in the vitreous cavity, and in real time fluorescein can come in the vitreous cavity, even in the live patient also in the 90D we can able to see one day this type of cells in the vitreous cavity. This is the epithelioid cell, already I have shown you. So different pathologies we have to document it, and see there is a spindle A, spindle B and epithelioid cell. Spindle A is a flattened cell with a enfolding of a nuclear membrane, and these are prognostically very good. Spindle be a bit plum shaped with a nucleus and nucleolate, and epithelioid cells are much more plum cells, and they are less cohesive, and most important, you have a nucleus and nucleoli, and they are prognostically bad. These are the mixed melanoma. This already I have explained this. And this is a epithelioid melanoma, and sometimes HMB45 can be done, or Melane or MITF can be done in those. What are the prognostic factors? Very, very important. So chromosome 3, chromosome 8, and chromosome 6, the words as well as the favorable prognosis. Size of the tumor I have already told, small, medium, large, and extra large. More the larger tumor, bad the prognosis. Extrascleral extension have bad prognosis. Anterior located tumor are worse prognosis because they are hidden under the iris and you cannot see them. And lymphocytic infiltration and local tumor recurrence are important. Now, close vascular Raman Font et al. Had studied the vascular pattern, 9 patterns they had found, and this is a close vascular pattern that we have seen. HMB45, how beautifully it has stained the cut end of the optic nerve. You see, this melanoma cell has stained in this. Vortex when invasion, very important. You can do innovative imaging as well as histopathology in this. And this is the choroidal melanoma seeds Ubaid and myself and my other co-author has published in a peer-reviewed journal. And to sum up, choroidal melanoma have varied presentation. 2 atypical cases I have shown you, and these are my selected reference. I like to thank Dr. Hemlata Deka, our medical retina HOD, Oculoplasty Department, Dr. Kasturi, Dr. Ganesh, Ocular Pathology Laboratory, Dr. Bidhan, and Mr. Apurvo. Thank you for patient hearing.
Thank you, sir, for the wonderful talk and beautiful documentation of all the cases, sir. Any questions to Dr. Dipankar?
Yeah. Sudh. Yeah, prognostic importance of this case, no? The pigmented cells were there around the spongiform thing. So that was the thing. This is the sclera, spongiform appearance. In some areas there are the pigmented cells. Whether there is a pigment migration occurs before this spongiform cell or after this spongiform change, we do not know. But one thing is that sometimes even in the retinoblastoma seeds, no, there are pigmentation happens, okay? And this is actually we don't know if you can make a study out of it of the pigmented cells in the tumor, okay? Whether they are a prognostic important, you can find yourself. So I think some sort of migration, they are signaling that there may be going to spread outward.